wonderful panelists joining us for today's session. Our first panelist is Dr. Sandra Newton, a clinical psychologist in the GTA with training in developmental, clinical, and school psychology from the University of Toronto. As a psychosocial program lead with SCAGO, she provides advocacy, education, counseling, peer support groups, and research support for individuals living with sickle cell disease. Our second panelist is Shaista Durrani, a social worker who practices in sickle cell disease at UHN, advocating for compassionate, person-centered care through a trauma-informed anti-racism and anti-oppressive lens. She has experience across healthcare, community, and justice settings, and has contributed to anti-racism and anti-oppressive policy initiatives. As for our final panelist is Heather Manu, a nursing student at Toronto Metropolitan University, a participant in the SCAGO Youth Empowerment Program, and an advocate with lived experience of sickle cell disease. Drawing from both her lived experience and clinical education, she is passionate about improving the mental health, psychosocial well-being, and healthcare experiences of individuals affected by sickle cell disease. Please join me in welcoming our three incredible panelists. Woo! And with that being said, I'll now pass it over to Dr. Sandra Newton to take us away. Woo!
Thank you, Samira. What a lovely opening. I appreciate that. I know we all do. And it is definitely a pleasure and privilege to be here today and to have the chance to present with these wonderful fellow panelists and to see you, of course. This has been a great summit, and I'm really glad to be able to speak about this subtopic, which you can see we're really focusing in this session, as you know, on mental health and psychosocial needs and resources and support. So you'll hear a bit of on each from each of us. But I'm going to take a bit of just guide you through my thinking here. So this is where I mention I have nothing to disclose and then go on to discuss the things I have to disclose. I'll work on it. But I did want to mention, of course, that I'm affiliated with SCAGO as a psychosocial team lead, and I also have worked with CAMH team, and you would have met them yesterday if you were here to hear about our collaboration on a making sense of pain adaptation. So I wanted to mention that. And then I was also teaching at U of T, and I just thought it would be important to mention it, although I really don't feel that these have substantial impact or connection to the presentation content. Good to mention it, right? So continuing, and I just got a tutorial on this. Look at me go, Dapo. Just to go through all of this. And I put this slide here because so many times when we're talking about psychosocial topics and sickle cell disease, we immediately begin with, talking about prevalence rates and how many people in Ontario have sickle cell and all of the things that we know go with it, the impact physically, socially, what we call pathophysiology, what's happening at the cellular level. And that is often the way we begin discussions about things like pain and so on. But I wanted to do something a little bit different today and, just getting to the part here about pain and say that I think we understand that when it comes to pain, it is, yes, a core, and some would say central feature of sickle cell disease for them. But there's so much more that's going on that we hope to highlight in this session. So I won't go into, maybe acute versus chronic pain. And many patients have said to me that that's really a distinction that seems false for them. There's so much more to talk about, and at least we have that starting point. Here's actually what I'm hoping to do. We were given the topic beyond pain, and I remember thinking about that and going, well, what is beyond pain? It's such a, as I've been saying, a central feature of the sickle cell experience from what people tell me and from what I know. And yet, I think we're being encouraged to just sort of broaden the lens from that center to think about all of the things happening around. Not sure if you can see all of them from where you're sitting, but if I go clockwise from the top, we start with the psychological. And that's not just the cognitive pieces, the impact of disease processes on your thinking and processing. but just your well-being, your mental health, in other words, and other adaptations and so on that we need to consider. And then, of course, the physical is not under debate. We know that this is very much something that affects physical functioning and so on. But I want to talk about how we expand that to the spiritual, the social, the economic and status. When I say status, I speak about immigration and other settlement issues. I think in our work with folks with sickle cell, we understand that it is so much more than just pain experience. This central piece flows into all of these, and it's important for us to understand how. So with that, when I speak about psychosocial considerations, I think we hear that term a lot, and if you aren't familiar with it, it's about thinking about both the psychological and the social impacts of a condition. And just this graphic just reminds us that when we talk about the psychological, it's more than just the cognitive and thinking. It encompasses all of these other things. So it encourages us to think of health beyond the physical, and even just beyond, mental health and thinking, but thinking about our social, spiritual, and emotional impacts. So just again, how do we sort of broaden the lens? I remember when I was working on some quality of life research or health-related quality of life research in children with sickle cell disease many moons ago, one of the things that came up often was the World Health Organization's definition of health. And it really urged just what we're talking about today, thinking beyond the physical functioning piece to thinking about the totality of one's wellness. And I think many people would say that, of course, physical health is a big indicator of how well you feel, but when your mental health and well-being has taken a hit, that can overshadow all or be just as challenging functionally. So just a quote from WHO, the World Health Organization, that came about in 2022. It says that mental health is a state of mental well-being that enables people to cope with the stresses of life, realize their abilities, learn well, work well, and contribute to their community. I think when I'm talking with people, one of their challenges is about how their well-being gets in the way of that contribution part, wanting to be a part of things, wanting to be with people, engage in their work or study or whatever they're doing, and how that is the crushing thing often, right? Not being able to realize that potential, that goal, and be a part of what's going on. And mental health is something which, just like physical health, needs to be thought of as beyond absence of disease. It really is a continuum for people that they go in and out of, right? Mental health is about being able to function in the ways that you want to. So that's something the person identifies, and in the aspects of life that they value. Again, working from the person's values versus what we think is important to people. And that's why our conversations with each other are so important, to find out what people want and what they want to achieve and be. So if we think about mental health as something that is woven into every aspect of our social, emotional, and physical lives, we'll understand the importance of caring for it just as much as we tend to emergencies of a physical nature. Let's think about mental health in that way, something that needs our attention, and assertively so. So I like to talk about what supports good mental health or positive mental health, because I think we can immediately go to the things that reduce it or diminish it. But if you think about what makes you feel good in terms of a mental health scope, just that positive sense of overall well-being. People might define it as feeling good. And that's not something you measure with number or things like that, but a person can speak about feeling good, right? And if we break that down a bit and look at it more closely, it could be also about how they're coping. So again, it's less about what's coming at us and much more about how well we feel that we're able to navigate the challenges and hardships that may come. It also means having the right resources. It's fine to put someone in a situation and ask them to navigate it, but if they're not able to feel that they're able to cope, it could be because the resources they need to do that are absent or not sufficient. We need to think about someone who's resourced for the task at hand. Just that feeling of predictability and stability in life, so important. And I think anyone living with sickle cell will tell you that difficulty knowing what tomorrow, next week, next month might feel like really hampers sometimes that feeling of feeling good, because the sense of control comes from feeling that there's some stability in what you're dealing with and living with, and predictability. Now, folks who have been dealing with this for some time have learned their ways of coping with this, but I hear it often as a theme in the work I do, just really wishing I could feel that sense of control, and the good thing is that many people are doing what they can to increase their chances of that. All right. And feeling productive and able to achieve, as I mentioned before, feeling like you can contribute. Some further things that matter, having physical needs met, sleep being so important. Again, beyond pain itself, the pain is actually affecting sleep, as are other processes in sickle cell disease. What about nutrition and other aspects of health? A sense of belonging. So now I'm expanding it to what the social meaning is. Knowing that we have value in our neighborhood, our family, our friend groups, our spiritual communities. And I've also put here access to the right kind of care, because good mental health also means knowing that if things do take a turn, there's a place to go, there are resources to access. And so these are ingredients we think about. Of course, poor mental health, I think we can all go there immediately and think about just upticks in someone's physical distress, having a crisis, having pain episodes that are enduring, struggling to get things under control, just feeling blocked in that way. So illness that doesn't feel like it's at a level that's within our coping resources. Grief and loss doesn't get talked about enough, and that is not always about losing a person physically. It's also unrealized goals. It's also anticipatory grief, things that we know are coming and feel helpless to change the pathways around. It can also just be about the economic and financial challenges, and those are just the stress is what I'm speaking about. And we do know that stress and pain are related in terms of episodes and how people experience them. But these are all things that can chip away at that resilience that's needed. So I put those there, and there are more that we could add to the list, but just to, again, always thinking about how we expand the view. When we're thinking about psychosocial impacts of sickle cell and pain being that, yes, at the core, but also related to so many other things, we can't ignore the fact that there have been some really well-done studies, and they let us know that depressive disorders and anxiety disorders are well represented, right up to a third having anxiety disorders of all types, depressive disorders, so the mood being affected by not just the disease process, but how one is managing that. And when you dig a little deeper into the papers, you find out, just going left to right here in my panel, right, that mood disorders up to 50% reported in some studies. That's a lot of people, right? And as I've said, mental health has just as much of an impact on your functioning as physical. You can imagine low mood getting in the way of achieving the things that you value and feeling a part of society and that you're productive. If we look across the lifespan, children are certainly reporting those challenges in their friendships and self-esteem, and just feeling, again, part of a group, able to keep up, do what others are doing. That tendency to compare to age peers is really powerful and can affect the way one sees oneself. I don't want to lose the message around caregivers. I see Mary here, and she's always reminding us of how important thinking about the caregiver stress is, and I think that goes here as well. And people, of course, are aware of the impact on their families. That's another piece of potentially guilt and stress. And when one is navigating healthcare, coming invariably, although I'm hoping that things are changing, people do still continue to report challenges with accessing equitable care, feeling duly respected, and having their pain and experience validated appropriately. So those are our struggles that are compounding this life with sickle cell disease. We know that ingredients for helping to improve a person's experience in terms of health and wellness has to do with education, not just their own about their health, but also that of the people that are giving care, making sure that there's a plan around symptom management. We may not be able to eliminate pain in other episodes, but we can at least make sure there's a plan that is referred to and that is refined as we learn more. And then, of course, support, all meanings intended, not just medical care, but community, social support, and so on. All right. And I really wanted, I may need to move through some of these just for time, but I really think it's important in speaking about psychosocial things to talk about the intersections. And intersectionality is a term that I think is being heard more and more, coined by Kimberly Crenshaw, very much a legal precept, but coming more and more into our discourse is understanding that there is a cumulative effect of a number of different inequities for particular groups, and certainly those that identify as Black, those are not the only people affected by sickle cell disease, but absolutely the lion's share here in Canada anyway, and elsewhere. Folks are not just sort of navigating a disease, they are constantly experiencing institutional examples of anti-Black racism, thinking about how that affects the care they receive and how they live in the world. I would also mention that social and economic conditions are an important consideration for this group because, again, invariably, because of inequities in our systems, folks are also dealing with housing, economic, employment challenges, access to education that's disrupted. These are compounding things that also affect one's mental health and well-being. I think that goes without saying. There's an important stat. These are drawn from Ontario Health Publications, and there are references below that you probably can't read, but I can make sure they're shared. You know, we have a lot of information about the fact that income and social pressures by neighborhood are significant, and there's overrepresentation of Black people there. And some of those people are living with sickle cell disease. We know, again, back to caregivers, that many are also dealing with their own impacts of not just stress, impact on their earning potential, and their overall well-being. So a lot is going on at once. I might just move through some of these here. Okay, actually, doing all right. Let me just share, the what do we do about it? And the nice thing is, with awareness of these things, there's a lot that we can do as those in a helping role to try to mitigate some of the impacts. We can make sure that the care is thinking holistically about folks. Counseling or therapy that's supportive, I would encourage culturally sensitive, so that we're actually meeting needs in the way that's needed rather than some generic approach, which is super important. Understanding that peer and social support are invaluable to those navigating sickle cell disease. And I would say meeting practical needs is super important. It's hard to talk about stress reduction and coping if we're not also talking about meeting the needs people have in terms of social assistance, housing, food, transportation. A large subset of the folks that we are supporting through our programs are people that are here with status that feels tenuous, right? And are maybe not insured or struggling just to access the care they need to live out the lives they want. So we really need to be thinking about how to meet those needs in different ways than we do currently. Can I go back? You can go back, okay. The importance of care being responsive, and that means not just supportive as in we're offering care, but informed by what patient preferences are and truly trying to co-plan with them. I think that so many people struggle with feeling informed about the plans around them and for them, and that's another form of feeling quite invalidated by health systems. So we can do more there. There's some other suggestions given on the slide as well, but just moving toward the close. A reminder as well that the way that we approach folks with sickle cell disease, thinking about all of these vulnerabilities and also that there are resiliencies in there, I don't want to lose that message, is that if we really center that listening stance, I heard that mentioned many times yesterday, I think clinicians get it, but people want to be heard, and not just heard, but actually engage with what's being shared. And people want knowledgeable caregivers and clinicians, people that they don't have to teach about sickle cell in general, although they may need to inform them about their particular needs. Really thinking about how we can do more to make care equitable and accessible, and being attuned as whoever we are, whether we're a family physician or a social worker, psychologist, anybody that's trying to meet needs, thinking about indicators of distress and actually bringing the mental health piece into our conversations, going beyond, again, pain, to look at people more broadly in their situation. situations and contexts, and absolutely connecting to resources and following up. And then there's just more here about just the number of ways that we can help. Yesterday I had the chance to present with both a social worker and occupational therapist from CAMH, and we've been talking about how some of those other allied healthcare pieces can be part of someone's care. Pharmacists are a big part of care in their program, but not always people that are being accessed. So again, in the spirit of broadening who can help and how, just some suggestions about places that we can make available to people to access care, and actually doing what we can to bring practical support back. So I know I've gone over my minute, but I just wanted to return to this slide, which yes, I might have had some assistance making, but I like it because it shows the interconnectedness, and with a wheel, I think at different times, different things are at the top, bottom, left, and right. As we think of pain, just some encouragement to think about all of the things operating around specifically mental health for this talk, and how much we do well to buttress and provide services that strengthen that in the name of creating better health and well-being overall. So thanks everyone, and I think questions are later? Okay, I hope you'll ask if you have any. Thank you.
Thank you, Dr. Newton, for that insightful presentation. Next up, we have Shaista Durrani.
Sorry, I just learned how to use this, and I'm already screwing it up. Okay. Thank you so much, Sandra, for that wonderful presentation. It really reminded me of what Daniel said yesterday about how he would go to his medical appointments and it would be so medically focused, and he commented on, what about my mental health, which I think is so critical for patients. We're often they're only seen for their physical health conditions, and everything else is sort of ignored, yet they are there as a whole person, and that's how they should be treated. So I've been a social worker for almost 20 years now, and I've actually never had to fight a system as hard as I do for people with sickle cell disease, because that's exactly how many barriers are put up for our patients. I feel like every day is fighting a system that's failing people with sickle cell disease, and it doesn't stop at the walls of the hospital. The system that has failed my patients has failed them since they were born. The adversities they face have been constant, whether it was in a hospital setting, in a school setting, in a workplace setting, or within the neighborhood that they live in. Despite that, patients remain resilient, and I'm grateful for what they've shared with me. It does make me sad to think that I'm still here like 6 years post George Floyd, and we're still talking about systemic racism, and we're still talking about equity, and we still have to have these conversations. It's exhausting. It's exhausting for our patients, especially, to constantly be having to explain themselves since they were children, basically, within this system. So the current slide on the screen is basically a breakdown of referrals that we typically get in my clinic. So my clinic has 2,600 patients. We have, at our full capacity, 2 social workers that are full-time, which is not a lot for 2,600 patients. So the predominant referrals that we actually get are for financial stressors, workplace support and accommodations, healthcare navigation. And when I actually look at the data, 42% of the referrals are issues related to poverty. That includes financial stressors, housing, medication access, and the criminal justice system. Much of the work that we actually do in a hospital setting and an outpatient setting would actually not be typical of outpatient social work within a hospital setting. I almost feel like if we didn't do this for patients, the system won't do it for patients. So I always say there's probably about 40 different types of letters and forms that we work on for patients, whether that's for benefits or accommodations, follow-up to workplace accommodations. If we don't do it, it's very unlikely that their family doctor is going to do it for them. Many of them don't have family doctors, and they're just going to get lost in a system that's already very difficult. And that's one place where I think we do need to see more change in terms of just the paperwork that's needed for all these different benefits, the approval process, the appeals process. It's very exhausting for our patients, and it also puts a lot of pressure on the medical system. I've also had patients who have been in and out of inpatient units within the hospital for much of their life, yet never met an inpatient social worker. So no one's actually coming to them to address their mental health whatever's going on, even just to say hello. I've had patients who have been in the hospital for months and only met an inpatient social worker when it was time to get the bed, when it was time to say, like, we need to discharge you. Is it okay if we discharge you here? Yet they never met that person. And they're sort of kind of all on their own, advocating for themselves, and many of them don't want to be there. They actually would say when I visit them in the inpatient unit that I don't want to be here. I'm not even getting the care that I need. I think I should just go home, or maybe I should go to a different hospital. And they're not really being heard. My work revolves around validating people's lived experience, building trust, and creating safe spaces for sharing and integrating equity and justice into the work I do. It's not enough to just speak to patients, yet not take a stance on advocating for them on important matters. Because you can listen, but if you don't do things that are actionable, it's not meaningful for a patient. So, sometimes if they're having a housing issue, it is about advocating. I've even gone as far as, gone to the city councilor for housing conditions for our patients, because that is something that, as a social worker, I do feel is my responsibility to do. Yet you won't see that in a lot of outpatient care in general in a hospital setting. This population is a population that faces severe judgment, systemic racism, and holds a lot of medical trauma, which is really important to address and to speak about. And there has to be a space to listen to patients and value them as the experts of their own life, because they are the experts of their own life. This morning, the speaker sort of spoke about, the elephants in the room and like what people don't want to talk about. And I think a lot of times with people with sickle cell disease and providers is not wanting to speak about the disparities in any meaningful ways and not wanting to talk about the systemic inequalities. So on the screen, I have social determinants of health. So when we're often helping people, we're thinking of it with a very medical lens, yet many psychosocial factors are lost. And I understand that sickle cell disease affects people of different backgrounds, but most of my patients are Black, and that is why I'm focusing on Black communities right now. Social determinants of health are the non-medical conditions and economic factors, such as income, housing, education, that shape daily life and heavily influence overall health outcomes and quality of life. So you're not going to be healthy when you're homeless, facing eviction, facing living in unsafe conditions. And you're not going to be healthy, if your workplace is discriminating against you because you're asking for accommodations due to your medical condition, which often happens with our patients. I also do want to touch on home ownership, because for Canada anyways, home ownership is the vehicle to wealth. That is just a fact. That is how the economics work in Canada. And if you don't have access to that, it interferes with intergenerational wealth. It interferes with your security of tenure of housing. So we have Black Canadians having 43% home ownership rates versus 70% in other groups. Eviction filings in Ontario are actually the highest in Black majority neighborhoods, so there's been research done on this. In some neighborhoods, it's as much as 36% of residents that are being evicted that are actually Black. I think the school system is another big one, where we see 42% of students that are being suspended, or 42% of, Black students are being suspended, which is huge. And that sort of shapes their life, right? Like, it shapes where they're gonna go in life, it shapes their trust in the system, and it affects them for the rest of their life. And there's also environmental factors. We know that in marginalized communities, for example, there's less trees planted, so they have access to less shade. And that is due to systemic racism. We also know that youth unemployment rate is getting higher and higher, but it affects Black youth even more, where they're having double the rates of unemployment. And I think, like, when looking at young people in general in Canada, we're already seeing young people being very disenfranchised. They're going to school, they're trying to do everything they can, but they have rising unemployment rates, they have a housing crisis, they have a cost of living crisis, and it's already depressing, it's already affecting their mental health. And Sandra mentioned intersectionality, which is where we can see people with sickle cell disease facing even more barriers due to the race and disability. So it affects them in even a more different way, which means that there needs to be more unique strategies to deal with this. And I also want to talk about racial trauma, because I think that that's one that many patients actually come to us because of. Like, racial trauma comes up constantly in our conversations every day. There was a research study out of University of Ottawa that basically showed 67% of the people surveyed, Black individuals in Canada, report higher symptoms of PTSD, which is linked to racial microaggressions, and 40% of Black youth experience racial discrimination in school, which increases the rate of depression and trauma. So it's just an added trauma, and I think that it's important to actually be able to discuss this safely in a healthcare setting where, if a patient is coming and they're saying that, I do think that there's racism happening, we can't shut down the conversation, not want to talk about it, and just ignore it. And I think, sometimes when I even go see patients, I will tell them that I do think that you're being treated this way because of your race, and they actually say, thank you for saying that. Because I felt that, but I was scared to say that. I'm scared to speak up because I think something's going to happen to my health if I speak up and I take a stand. So sometimes they need somebody to help them, to talk to the care team. How did they feel? What was that experience like? And I think that the work that SCAGO is doing in terms of getting patient feedback is critical. Looking at that from a data perspective is huge. I think that that is very impactful. I also think, oh, sorry, I was on the wrong slide, by the way, so sorry about that. The importance of anti-racism and anti-oppressive work in the therapeutic work that we do, I think that's critical. I actually don't think that you can work with individuals with sickle cell disease without having a background in anti-racism and anti-oppressive practice. I have a very strong stance on that. And it really begins with critical self-reflection. So I know I'm racialized, I'm brown, I'm South Asian, but I also know that that comes with a lot of privilege for me, in terms of what my patients are going to go through so many more systemic barriers. They're going to go through so many systemic issues within school, within their workplace, within the healthcare system that I'm not going to have to go through. And I think that as providers, people have to kind of take that responsibility on to themselves. So if you didn't get formalized training in anti-oppressive practice or anti-racism, you have to go and get that for yourself. But it all starts within your own self and being able to recognize why those systemic differences exist and not to take that personally. So if a patient comes and they say, I've experienced, racism, it's not something that you need to take personally. It might actually be a systemic problem that needs to be solved. And also recognizing that social justice work is therapeutic work. It is therapeutic for patients. So like a lot of the times, people will say, well, do you do therapy with patients? It is a form of therapy, is what I want to say, that you can't help someone with their, housing situation without it being therapeutic, without discussing the racial trauma, without discussing the trauma and the feelings that they're having. And also valuing the person as the expert of their life, but also championing equity within your organization and systemically, so even outside your organization. Some of the challenges to providing people with sickle cell disease mental health therapy, and therapy in particular with their sickle cell disease, is actually a lack of dedicated trauma-informed spaces for patients with sickle cell disease. I mean, I've had to meet with patients in the hallway. It's not appropriate. We need organizations to actually have spaces that are safe and spaces that are not where they had their medical trauma. Because, having a therapeutic session in a room that's just a medical room where they felt the trauma is not an appropriate space. And also, there has been a limited uptake of anti-racism, anti-Black racism, and anti-oppressive education. Many hospitals do not have that as a mandatory education. It just doesn't exist. And that has to be from a provincial level where that actually happens, and perhaps even mandatory race-based data collection. And the other point I want to make is that a lot of people that are actually providing services to people with sickle cell disease are racialized themselves and also are having vicarious trauma because of the work they do, and there's limited supports for that as well. I also want to talk about the need for dedicated therapeutic support for caregivers. There's not a lot of support for caregivers. They have very limited access to respite services, and it's a very long wait list to get respite services. You could be waiting 12 to 18 months at some organizations to get respite care, and that's too much. And they're breaking apart mentally and physically, doing caregiving work, and they don't have the resources. There has to be a lot of advocacy for home care services. Many of our patients end up in the hospital, absolutely should be referred to home care services. When they're discharged, are not actually getting referred to home care. So we have to do the home care referrals from an outpatient setting, which causes a delay in them getting the care. And also a need for culturally sensitive therapeutic resources for caregivers as well. I did include a whole bunch of different slides of different kinds of therapies and stuff that we offer at our clinic. I will let you guys just review that whenever the slides come out, but I did want to touch on one therapy that we're doing, which is the acceptance and commitment therapy. So we're going into our third cycle this fall. Our groups are pretty small, so there are 8 people, 2 hours a week for 8 weeks, and it's open to patients who have sickle cell disease or thalassemia. It's very psychoeducational. With homework exercises that you do on your own time, and then come back and share. The therapy isn't about altering thoughts or negative behaviors. More it's about accepting things. It's about accepting negative thoughts and emotions, and it helps individuals to become more mindful, more focused on the present moment. It helps people with anxiety, with depression, with pain. And one of the biggest things I think that was a benefit of this group was actually just bringing people together. That was actually the most powerful thing. So the therapy was one part of it, which was wonderful, but it was actually seeing how the patients connected and how patients of different ages connected, and the absolute need for those dedicated mental health services. I know I'm running out of time, so I just want to quickly go through the last slide, which is basically what we need kind of going forward. I think that we need more patient voices and perhaps even a mental health needs assessment where patients tell us actually what they need from a mental health perspective, what kind of services that they would benefit from. I also think the need for more paid lived experience positions, so people who are actually doing lived experience work but actually getting paid. I also think that we need more trauma-informed services. We need more staff that have experience in anti-racism and anti-oppressive practice, multiple different therapeutic modalities. I don't think that there's a one-size-fits-all approach. I don't think we can give CBT to everybody. I don't think that's appropriate. I think we have to see what do patients want. And I always ask patients, you know, it's very important for me to ask them, is it important for you to have someone that's the same race as you as a therapist? And many times they say yes. And I think that we need to think about those things. We also need to think about funding for caregivers. It's very limited, and there's even more barriers due to systemic racism. I also think we have to look at the mandatory training across the healthcare sector and advocacy pieces to consider our transitional housing for people with sickle cell disease. So we have a lot of people that are in and out of the hospital, and it does cost the healthcare system more money to do that than possibly have transitional housing where you have wraparound services, where you even have medical care on site, which would actually be cheaper than using the hospital. And I think there has to be an analysis done on this in terms of the cost to the system versus the cost of transitional housing. I also think that a legal clinic for people with sickle cell disease is very important. If you look at the work that HALCO has done, so that's HIV AIDS Legal Center in Ontario, they've done amazing work for that community, where that community was severely stigmatized historically, but it actually took community partners, it took people working with people with AIDS and HIV, and it took lawyers, a lot out of them, to basically make systemic change and legislative change, policy changes that resulted in better outcomes for people with HIV and AIDS. So I think that's a community that the sickle cell community can learn a lot from, and also invoking some disability eligibility changes from ODSP, which is something else that HALCO worked on, and it's something that we can learn from. Thank you so much, everybody.
What a wonderful presentation. Let's just give another round of applause. Loved it. Next up, we have our final panelists, definitely last but not least, Heather Manu.
Good afternoon, everyone. Thank you all for being here, and thank you guys as well. So I'm a nursing student at Toronto Metropolitan University with lived experience of sickle cell. So my nursing education and my lived experience has shaped my passion for advocacy, compassionate, and trauma-informed care. And so today I hope to bring both perspectives to this conversation. Honestly, I don't really have anything to disclose, but I think one thing I will say is I'm a SCAGO Youth Empowerment Program participant. I'm a nursing student at TMU, and I'm also a clinical extern with William Osler Health System. All right, so sickle cell disease is more than a blood disorder. For many individuals, repeated experiences can influence trust, mental health, and even the willingness to seek care. So today I want to look beyond the clinical management and explore the patient experience, including social determinants of health, anti-Black racism, stigma, trust, trauma, and mental health. And I'll do this through personal storytelling, supported by evidence using 3 themes that I want you all to keep in mind. So voice, am I heard? Perception, am I believed? And identity, am I seen as a person? So before we look at the patient journey, it's important to remember that sickle cell exists within a person's everyday life. Social determinants of health, such as relationships, education, and employment, can influence health, and at the same time, sickle cell can affect physical health, daily life, and our overall mental well-being. And this relationship, it works both ways. So pain, fatigue, oh my God, sorry guys. So pain, fatigue, and many hospitalizations can really disrupt school, work, relationships, and everyday responsibilities that we all have. So when someone enters the healthcare system, we're treating a whole person, not simply a disease or a pain score. All right, so now let's meet our patient. So usually when a pain crisis begins, they initially try to manage it at home. And if that doesn't work and the pain progresses, they go to the emergency department where they seek care. They'll be assessed, and then they'll have pain management. And then sometimes if it doesn't work out, they'll be admitted where they'll be hospitalized and stayed on an inpatient floor. And then eventually they will recover. So clinically, this pathway looks familiar to many of us. But what happens within that journey matters. All right, so one morning, this patient presents to the emergency department experiencing significant pain. They communicate what they're experiencing, and eventually they wait approximately 12 hours to be seen. Someone who knows the patient eventually advocates on their behalf. They recognize what's happening and then they advocate on their behalf. And so advocacy can be incredibly important, but this experience raises a question. Why does someone else's voice have to carry more weight than the patient's own? Honestly, when you're experiencing severe pain, advocating for yourself can be extremely difficult. So think about what an experience like this communicates to a patient and the value of their own voice. Now let's meet the same patient during another healthcare encounter. This time they've arrived wearing scrubs, and they notice a difference. They feel they're spoken to differently, their concerns seem to carry more weight, they're assessed thoroughly, treated with respect, and even involved in their care. But it's still the same person, the same diagnosis, and the same knowledge of their own body. The visible difference is how they're presenting, like what they're wearing. So what did the uniform communicate? Is it professional status, healthcare knowledge, credibility? And should perceived professional status influence how credible a patient appears? Something to think about. So during another healthcare encounter, the patient hears themselves being referred to as a sickler. So this is one word, and it may seem insignificant to the individual saying that, but when we replace someone else's identity with a label, the person becomes the disease. Their individuality can disappear behind the assumptions associated with that diagnosis. So when does a diagnosis stop describing someone's condition and start replacing their identity? So I presented these encounters as someone else's story. However, this is my story. I was a patient who waited in the emergency department for 12 hours in a hallway with no call bell. I was a patient who needed someone else to advocate for me because I was unable to. I noticed the difference when I entered the hospital wearing scrubs. And I was the person that was referred to as a sickler. However, I'm not a sickler, I'm not a drug seeker, I'm not a frequent flyer, and I'm not a difficult patient. The patient has a name, and it's Heather. That's my name. Thank you. Okay, so my story raises those same questions I asked you all to keep in mind. Voice, was I heard? Perception, was I believed? Identity, was I seen as a whole person? But my lived experience cannot tell us whether these are broader issues within sickle cell care. Lived experience provides the story, and evidence helps us understand the broader context. And the evidence brings us to 4 interconnected areas: anti-Black racism, trust, trauma, and mental health. So research shows that sickle cell-related stigma and anti-Black racism can intersect within healthcare. Implicit biases and racialized stereotypes can influence how a patient's pain, credibility, and requests for treatments are perceived. So patients may be labeled as drug-seeking, exaggerating pain, or difficult. Researchers have even documented a young Black patient with sickle cell disease being referred to as a sickler, which is extremely dehumanizing with racial overtones. And this particular article, it really stood out to me because I experienced the same thing, unfortunately. So Ontario Sickle Cell Disease Quality Standard, it recognizes racism and anti-Black racism as quality of care issues and calls for care that is compassionate, trauma-informed, free from racism, discrimination, and stigma. So the words and assumptions we bring into an encounter can influence the care that follows. So this is where trust, trauma, and mental health become connected. Repeated experiences of disbelief, stigma, or discrimination can erode trust and change how someone approaches future healthcare encounters. Trust is also influenced by whether patients feel involved in their own care. For example, during a pain crisis, a patient's usual medication or dose may be changed without collaborating with the patient. And this is something that actually happens quite often. Patient-centered care means involving the patient in decisions through shared decision-making. These experiences can also accumulate psychologically. And research has linked discrimination and with internalized stigma and depressive symptoms. But thank God, there's been important progress in Ontario through advocacy from organizations like SCAGO, and with support from the Ontario Ministry of Health, sickle cell has received greater attention and investment. And this has really helped strengthen specialized sickle cell services, supported efforts towards standardized, equitable, and patient-centered care. SCAGO has also continued supporting the community through advocacy, education, awareness, and patient and family support. It demonstrates what can happen when community voices are included in healthcare improvement. And this is why the healthcare encounter doesn't necessarily end when the patient leaves the hospital. A poor healthcare experience can really contribute to loss of trust, emotional distress, and anticipatory anxiety. Eventually, someone may be reluctant to seek care, and even when they need it. Then another crisis occurs, another healthcare encounter happens, and the cycle begins again. And then the patient may be wondering, will I be believed this time? Will I have to prove my pain? Will I feel safe? So the next healthcare encounter can begin psychologically before the patient even walks through the door. So now how can we interrupt that cycle? We can do that by listening to the patient's voice, because their voice is valuable. We can reflect and consider on how our perceptions or biases may influence an encounter. We can recognize the person beyond the diagnosis. We can recognize and address racism, stigma, and inequity when they appear. And we can build every interaction as an opportunity to strengthen trust. And we should remember that the emotional impact of care, it may continue after the patient leaves. So as a clinician, you may not remember every interaction with the patient, but we remember. Even if it's been like 10, 20 years, we still remember. So if you're a clinician, I leave you with one question that you should carry with you. What will your patients carry with them when they leave your care? These are just the references that I used for my presentation. And thank you all for being here and listening to my presentation. Thank you.
I think the audience speaks for itself. Wonderful, wonderful presentation. Thank you to all our three panelists. Let's just give one more round of applause. Amazing. We will now move into the Q&A segment of this session. If anyone has any questions, kindly raise your hand and I'll bring the microphone to you.
I hope to.
Oh, okay.
Hi, thank you all for the presentation that you guys delivered. It was wonderful, very insightful. I can relate to all aspects from the different perspectives shared. I believe, is it Sandra is the one in the, Dr. Newton? And then they, Shaista and Heather. Okay, so Shaista, I have a question for you. As a parent who is currently navigating the education system with a child who's in and out of the hospital, what is your advice when a child has missed school for a number of weeks and then having to, to reintegrate back into the school system, and then that becomes a cycle, and then you're asking teachers to help, and there's a bit of resistance there, and then your child has now missed learning lessons as a result from being in the hospital. What's the best way to navigate through that process?
Yeah, so I think there's a few things there. So one thing that's very important, and that's why I feel very strongly about this with caregivers, is they need the therapeutic support. Like parents need someone to be able to talk to, and they need someone to help them advocate. Because I think the sad part of what Heather has even talked about is that often people are not listened to, and they need someone to sort of help them. You need documentation, you need letters of support. So if you are associated with a sickle cell clinic or a medical care team, to get the note, like a detailed letter from the doctor. And it's your right whether you're going to have that discreet letter or not discreet letter, but I think sometimes giving that information, like what does it really mean to have sickle cell disease and how does it affect people? Because a lot of people out there have no clue how much it affects people, and they need those details. And they sometimes, you know what, schools still won't listen because there's a lot of discrimination, and we know thanks to mandatory race-based data through the Toronto District School Board anyways, that we have that data to say racism does exist. And it's not wrong to escalate your concerns, and sometimes you need to do that, and sometimes patients and their families have to go all the way to politicians to do that. I'm happy to discuss it further, but it involves a lot of advocacy and it involves a lot of escalation. And I have to say it's very exhausting for parents and patients to constantly have to go through that advocacy and constantly try to prove that their child has something that is considered a disability in Canada, right? So I think it's a lot of advocacy work, but I don't think that people should be left on their own. I do think that you need the help of a medical team to assist with it.
Thank you so much for that insight.
Karen, I'm glad Karen said that because, if you don't mind, I know that we're on time and we have other questions, but it's a great question for anyone. And thank you for mentioning that the resources exist. They are not things that schools will take it upon themselves to search. We provide it every year, have that anticipatory conversation. And I would also say the communication with teachers is key, having that early and ongoing. When you mentioned counseling, I'm so glad you did, because there's also a conversation that needs to happen with that child who is thinking about how they're going to re-enter and all the things they've missed and are maybe already feeling hopeless and helpless. And it's super important to talk about that. And then I was going to say, as someone who works in schools as well, there are a number of provisions for students that have medical difficulty. Again, hard to know those outside of systems. So I love the idea of advocacy, and I also think learning how to connect with the right people within school boards, which are huge, is another piece. So I hope folks will bring those things to the attention of someone like Shaista, someone like SCAGO. We do this work all the time, and we also have some parents that would gladly join alongside. Yeah, thank you.
Hi. Shaista, you mentioned about the legal aspect, and I am in full agreement that I think that would be a great aspect to help with warriors. ODSP, a bunch of different things that they have to do, those legal paperwork to navigate, and even when they are able to navigate it, still being turned back. So having that legal aspect to put that emphasis on what you're doing. My question is, has there been anything started in regards to that, and how do you suggest that steps get taken in? Because I think it's a very, very important step along with the counseling. As somebody who is a warrior,
Sure.
we plan. Sorry, go ahead. I'll do the other question after. Go ahead.
No, go ahead.
As somebody who is a warrior, there's many different aspects in which counseling is needed. For me personally, sometimes you're going along, and you've made plans and you're living, and thankfully things are going well. And right in the midst of it, a crisis happens. And yeah, eventually you knock yourself up, you dust your legs off, you get up and you move on. But mentally, it is extremely tiring and draining. And I think that's also one of the areas that needs deep counseling. As an adult, we've learned to navigate, but for that 4-year-old, that 6-year-old, that 10-year-old, who doesn't completely comprehend what's happening, but has missed 2 weeks of school, may have had something that they were looking forward to, and that opportunity got missed. And children can be very cruel to each other, Not that they're always intentional about it, but that cruelty can come. Those things need counseling. So both on the counseling aspect, and I know there's some already, but on a more deeper, consistent level, that and the legal aspect. Can you speak to what may be in play to get that in, or what needs to be done for that to happen?
Sure. So the legal aspect is actually a very important one. Every week I get referrals for people having legal issues, and it's actually probably every day there's a legal issue that comes up, whether that's at the LTB, whether that's in the workplace, whether it's a wrongful dismissal, whether it's a denial of ODSP benefits, whether it's a denial of DSO services. It's there's rejection, there's denials, there's obstacles along the way. Now, legal aid funding has been given to certain organizations that are more race-based, so that does exist. But like the HIV community, sickle cell, the sickle cell community requires their own. It requires lawyers that have a background in sickle cell disease, that understand these systemic barriers, that understand it from a disability lens. So some of our patients, for example, they end up going to an organization that is more maybe race-based, that is more, we serve marginalized populations. They're still not getting the services they need because people do not understand the disease. And I don't think it's enough to just educate those legal centers. I think they need a dedicated legal center due to the amount of barriers they're facing, both race-based and based on their disability. In terms of making that happen, I think that there needs to be more discussions with the HIV community and sort of like almost emulating what they did within the system. And it's going to require funding. And unfortunately, in Ontario, legal aid funding has been cut. So I think that there needs to be a case made to politicians of how important this is, but also how much it actually costs the system. All of these issues cost the system money as well, right? Like even the experience of racism costs the system money. And we see it constantly where even with immigration issues where patients will come to us and say, can you help us with our immigration paperwork because we're not getting the help we need from legal aid. So they're not even getting the help they actually need. And we spend a long time actually creating letters and actually almost doing some sort of legal work for patients. So unfortunately, it's not something that we have right now for people with sickle cell disease. But I think an organization like SCAGO, maybe, I know there's so much that they do and there's so much that they advocate for, but it has to be SCAGO, but not just SCAGO. It has to be doctors coming and saying that we want this for our patients. It has to be providers, and it has to be lawyers within the community saying that we know that this is a need and we need it. So when you look at what the HIV community did, a lot of the lawyers actually worked on that, and you've seen a lot of changes happen within that community. And I think you touched on counseling. It's the same idea with counseling. There's services out there, there's services that are more culturally sensitive, but we also need services that are for people with sickle cell disease. So for example, we had our ACT group. It was a partnership with mental health and medicine, but one thing that I've sort of gathered about it is that there's not enough focus on actual sickle cell disease within that counseling space. And I think that we need to see more of that. And it's going to require money, it's going to require dedicated resources, but it's going to require everyone coming together to push for it. I don't think SCAGO can be on their own. I think that they need support as well to make that happen.
Thank you very much for your presentation. As a teacher and a parent, I just wanted to share some few tips for parents in the room who may not be aware of what you can do to support your student in case they have to stay in the hospital for 2 weeks to a month. Once you're registered for school, you'll be given a form that is called a plan of care. That is where you put in details how you want your child to be taken care of when they report that they're feeling ill at school. Then you're going to be meeting with the spec ed team. They will be the one to make sure that the teacher is putting these modifications in when they're teaching your child. So when your child is absent, they can put something together, bullet point form, something very short, a summary. One step further that you can take as a parent is always request the long-range plan for the year. This is like the course outline for the entire year of what your child will be learning. So from September to October, there are different strands that need to be covered. So once you have this as a tool and your child is recovering at home, you can go ahead and get certain resources depending on which month your child was in the hospital, and get your own child to watch certain fun videos about those topics. And then reach out, if you have a Google Classroom, reach out to your teacher to answer certain questions about, okay, what did you focus on? Because sometimes there are many holidays in the month, so it's not everything we can cover. So the main important ones, those are the ones that we cover. You can ask them, which expectations did you teach the students? And you can do the same thing at home. Another thing is, for assessments, you can talk to your teacher, especially if they're in the junior intermediate grades, and ask them, how are you using your triangulation of data? Are you only just doing testing and then basing the child's grade on that? Or are you using classwork, what you're doing inside their books, how they're doing group work, and then giving the child a grade? Because at the end of the day, the grade is based on how the teacher saw your child learn. So if you have these open conversations with your teacher frequently and updating your plan of care forms and keeping the teacher in the loop, missed class time, I don't want to say it doesn't really matter, but it kind of contributes to how your child would do. And remember, a grade is just a grade. It's how we saw your child learn during that period of time. Anything could have been happening in the home to give them stress that they couldn't focus, right? So that's not how to see the child, no matter how they scored on their report card. So please have that open conversations with your child's teacher. And whenever I'm fortunate to have a student in my class who has sickle cell disease, these are some of the things that I do to ensure that the parents have peace of mind while the child is in my care. So I just thought I'll just share it out there. Thank you.
Thank you for that insightful information. It was super helpful. Now that is all the time we have for questions. Please join me once again in giving a round of applause to our three incredible panelists. As a reminder, please take a moment to scan the QR code on the screen so that we can get your feedback for today's session. We will now break for lunch and poster presentation in the Niagara room. Following lunch, our second concurrent session will begin at 1:25 p.m. Thank you again, and we will see you then.
Thank you, Samira. I hope everybody had a fantastic lunch.